That's fantastic. So we might go to the first one, which is a query on social prescription and who is going to be providing social prescription, who's going to be undertaking those roles, diversional therapists and recreational therapists, given that the focus is on psychosocial needs and this is a lifestyle specialist need and is positive with no storms and rain.
While we're waiting for Leah, Rajna, I'm quite happy to speak to that question if that will help. So the question was, given we all feel lonely from time to time, is avoiding the word loneliness probably reinforcing stigma unintentionally? I mean, I think that in some cases that certainly can achieve that kind of outcome. And certainly there have been many times when you run groups, and as Jen was actually saying, if you do working with people and mentioning the name loneliness, can actually bring up some of those stigmas, but essentially also what people describe is a sense of shame. Why is it that my life isn't going like everybody else's? It's actually something about me. And what we know from the research and from anybody who actually works in this space is that it isn't about individuals. Our society has also got some of those limitations, and I think it's really important points, some really important points that were raised by some of the speakers earlier in the first session, really highlighting the fact that this is really about a community and a societal related issue. So I do think avoiding those terms can certainly be something that's very helpful, and it's much more inviting. So I think that it's more about, look, you know, we want to make the most of our connections. So how do we actually build that, and maybe framing our interventions to harness and draw on the opportunities that exist out there to best effect and make sure they're a good fit for us. So I do think that maybe taking something like that approach might be more fruitful.
Sorry to add in, I'm just hovering about, yeah, we do have we have questions about loneliness in our surveys specifically that use the terms loneliness, and we approach it as gently as possible and have you know, information there about just so that it's clear that everyone experiences these feelings and goes through periods of loneliness. It's not just asking them kind of out of the blue, how lonely are you, but that we do try to approach it as gently as possible in terms of measuring that, measuring people's levels of loneliness and seeing how they improve over time. But definitely you can also get it at it by asking people about their levels of social connection and other kind of not specific to loneliness, using that language. Yeah.
Thanks, Leah. I think we also heard from Genevieve that using positive language rather than focusing on the negatives of loneliness, but positive on how people are feeling, was quite uplifting for people and didn't create a sense of failure from them, because you were asking positive, particularly in the survey components. I think you've also identified that this can be undertaken by anyone. You don't need to be a social worker, an allied health professional or a clinician. That the best approach, however, for social prescribing can be done by anyone who has the skills, the available information and the engagement opportunity.
Yeah, for sure. I just want to add to that, though, that we have spoken to a lot of GPs in our work and found that many GPs are quite reluctant to forward on their patients because there is, with social prescribing currently, a lack of accountability, I guess, because they don't have anyone to report to like other places do. So that's kind of why we've been kind of discussing a lot between the Queensland government and GPs about who is best placed to take on the role, and also because we don't have an accountability structure, that is kind of important, because you are dealing with quite vulnerable people and you don't want people to be taking advantage and not having anywhere to report to and things like that. So that's something just to keep in mind as well. But certainly anyone can do it if they have the skills. Then for sure it is something that can be done if you have the skills, and also possibly the capability of having training available so that people can upskill themselves.
Absolutely. Raina, you have a question, hand up.
No, it's more around the social prescribing and who does that, and GPs, because the RACGP have just announced that they have a new special interest group on social prescribing. They've been spending the last, oh gosh, I think it's 18 months or longer, working with the Consumer Health Forum to look at, well, what is needed to put in place to enable GPs to engage in social prescribing so that it is acknowledged, because many GPs already do this, and they're wanting structures and supports in place to make it easier for them. One of the things that everybody struggles with is to know what is available in the community that the person can access, and taking the time to be able to understand what matters to that person. Well done, Genevieve. What matters to that person, and then what would help them to achieve or to strive for what matters to them, and then link them to, and that takes time to do, and funding needs to be available to do that. But things are in place to support GPs now to try and access and build up their capacity and structures to enable social prescribing in general practice land.
That's fantastic, Raina. It's a fantastic movement, and I think it's probably not happening organically. It's happening because there is a move towards this. Researchers at university, researchers such as Bolton Clarke from Genevieve and her colleagues, they're actually creating some momentum. So we've got some momentum. There's a few questions that we can go to, and I suppose the first one we'll look to is Sue is asking, where can we find out more information about the special interest group?
So I put in the link in the chat box for this.
Put the link in the chat box for everyone?
Yes.
Good. Another query in relation to, and I suppose I'll ask you first, Genevieve, as you work at the Queensland University of Queensland, what advice can you give to providers of social connection activities who may want to engage with university researchers to help them evaluate their outcomes?
Yeah, so that's a great question. And when sort of COVID affected our plans, and we were really trying to cast a wider net and engage in more partner organisations so that we could increase our chances of meeting our participant numbers, we did have a number of other organisations sort of put their hand up. And I guess with every new partner organisation who wants to partner with us as a university researcher, that's an awful lot of sort of work that needs to be done to sort of action that. So we did allow that to happen for the ones that I've just listed on the slide, but then we sort of had to call a halt to it because we were spending all of our time doing sort of contracts and paperwork and ethics and all the stuff that comes with that, and not enough time on the ground sort of actually meeting with people and doing the work. So, I mean, I think most universities are very keen to partner and to develop those linkages, but just be aware that we're very thinly spread, and you know there's probably a limit to the amount of time and resources that they can add people. So I guess part of what my presentation was about is trying to help people to do it in-house and to actually develop those skills and resource packs that they could choose from to actually do their own evaluations as much as possible as well.
And just leading on from that as well, Genevieve, being able to prove effectiveness of any new program is important, and a big issue is the time it takes to collect the information as well as to collect the data. Have you got any examples, or can you give any advice, recommendation at all as to the tools that could be included for services most easily to use that will provide useful information, particularly if they're doing it in-house?
Yes, so the ones that I've shown on the slides, you know, most of them are published and in public, you know, you can actually make use of those. There are other researchers, of course, putting out toolkits. So I know that the group that Neve works with at Nottingham Trent have put out a social prescribing evaluation toolkit that's publicly available. So I can send a link to that to Raina and to the organisers for anyone who's interested. There's also groups like What Works Wellbeing in the UK, which is a sort of an organisation that really reviews a lot of evidence, and they've put together a kit of how best to measure wellbeing and loneliness and some of those concepts. So there's quite a lot of publicly available guidance and examples that will give you measures and toolkits and how to score them and that sort of thing. So I would sort of, you know, encourage people to have a little look and see what fits for their purposes.
We have another question in relation to what are those evidence-based strategies for people to overcome the barriers to social connection, and it refers back to the video where one of the ladies described they needed a little push. What is effective, and how do we ensure that everyone can benefit from these benefits? Rajna, have you, or Genevieve, first you?
Yeah, no, you go.
Rajna, have you got your hand up, or is that a...
I was actually wanting to answer a little bit about the previous question about the evaluation tools, and I'm sorry, I thank God, Jen, I couldn't get my hand down. I just wanted to raise that the National Academy for Social Prescribing in the UK and the Global Alliance on Social Prescribing have developed a groups of researchers who are putting together a living review of evidence on social prescribing, and one of the big things is evaluation. So they and Bogdan is going to be talking about this in the next session, and it's around leveraging off the work that these researchers are doing in compiling this information in a form that hopefully we will all be able to access. So I'm hoping, I did ask him to talk about this, so I hope he does mention that. Sorry, that was yeah.
Fabulous. That's the teaser for the next session, isn't it?
Yes, I know. Segueing.
Thanks, Rajna. Segue. Thanks, Genevieve. Back to you.
So I'm very interested in identifying and helping to remove the barriers. So that's actually quite a lot that we're focusing on in our project at the moment. My background is as a clinical psych, so I'm quite used to looking for sort of those thoughts and cognitive barriers, like the fear of negative evaluation and the mistrust and those sorts of things that people might throw up when they think of joining a group. And I don't think that people need therapy for that. It's not really a CBT type of scenario, but it's something where if they have a connector or a friend or, you know, someone they trust to help them overcome that, to get successfully embedded in a new group, it's much more likely to be an ongoing relationship. So relationships are key, but we do think there are those emotional, cognitive and other social kind of barriers, social determinants of health barriers, like I said on my slide, that are really important. We can't expect people to just turn up cold to a group of people they don't know and start, you know, being comfortable. There's a whole process involved. So yeah, that's an absolutely great question, and yeah, we're working on it.
I think
and
that's...
if I can pipe in here, Deidre, as well, just talking about connecting communities to care, and something that we've identified in our literature review is the need for that volunteer component, because the link or the connector can't do everything. You know, they're involved in finding out what's important and what matters to that person, but they won't have the resources or the time to be able to accompany them, you know, to the initial social activities. So we feel that that volunteer component will act as like a wingman to, you know, to go along and accompany the person, because they may be lacking some confidence socially, and helping them to, you know, integrate into that group. Maybe they go with them for the first couple of sessions, or maybe it's someone who just provides transport, or, you know, a follow-up afterwards, you know, someone to talk to about the experience. So that's, I guess, one strategy.
And can I add something there as well, that I think it's a responsibility that is across to the facilitators of those group activities as well. So a connector person or a link worker can do a lot of good preparation work with whoever's offering that program and vouch for them and describe it, and then have that person be skilled up and ready to receive and be welcoming to the new group member. So, you know, that's not just any old group, that will be particular groups that have got the ethos of what social prescribing is about.
Mm-hmm. And significantly, never more than we've seen in recent times through the pandemic, with people in isolation at home, perhaps not verbalising their loneliness, but actually lonely because they are either engaging either through telephones and mobiles and computer technology, but because they didn't have people coming into their home, there was no sense of shared experience, no sense of shared success or happiness. And hopefully we're coming out of that. We're seeing that we are, with COVID reducing, people becoming more free to move around into the community, and the opportunity for people to take on volunteer roles is more than ever. We saw that volunteer role drop off through the COVID pandemic. Now we're seeing it come out and improve and come to the forefront. It's a great opportunity for this to now move forward: social prescribing, social interaction, social engagement. Absolutely. Well, I just want to say thank you very much. There's no further questions. I want to say thank you very much to all of the presenters, Genevieve, Rajna, Kerry, and we wish Ron our very best in not being able to attend, but his document is certainly available. Thank you, and thank you for your time, your notes, and everything available.
Thanks for having us.
We'll now have a session 3. Hand